last part of our GDM. We already appreciated the importance of the patient education. So that is a very, very important part. Learn about the monitoring protocol in the GDM with a specific reference to the self-monitoring of the blood glucose. Discuss the obstetric monitoring of a pregnant diabetic patient. Learn the management of diabetes during labor and delivery also. Appreciate the importance of postpartum classification of the glycemic status in the woman with the GDM. So not only consider the pregnancy part, but also during the delivery and also the post-pregnancy period. So patient education is essential for ensuring the optimal outcomes. Encourages the pregnant woman to take charge of her own health and well-being. Most pregnant women want the best for their unborn babies. Education provides them the tools to achieve this goal. Basic knowledge of the diabetes and GDM, importance of regular follow-up, importance of compliance, this is very important. Compliance with the diet, with exercise, with the medication, with OBG consultations and physician consultations. Insulin storage and administration techniques. Sick day rules. What to do in case of hypoglycemia, that's very, very important. So this is the most acute complication the diabetic is in hypoglycemia. All diabetics should learn something about the hypoglycemia, adrenergic hypoglycemia, neuroglycopenic hypoglycemia, and how to treat hypoglycemia by themselves. Importance of retesting the glucose after the delivery. So that is 6 weeks, 6 months, yearly. How to prevent the future diabetes in the self and offspring. So they have to lose the whatever the weight gain they got during the pregnancy. About 8 to 12 kgs weight gain has to be lost after the delivery. So otherwise these people will become the obese, and obesity will invite type 2 diabetes much early in the mothers of these GDM population. So monitoring in the GDM, monitoring in the pre-existing diabetes, frequent monitoring of the glycemic control and prompt changes in the management are essential to ensure the good outcome. The options for the monitoring, self-monitoring of the blood glucose with your glucometer, HbA1c, serum fructosamine and glycated albumin. See, HbA1c means you have to wait for about 3 months or 4 months, depends on the RBC lifespan. Whereas the serum fructosamine and the glycated albumin may be 1 week to 15 days. So in GDM, I think fructosamine is much more superior than the HbA1c to have a long-term control. At least 15 days control, you can get it from the fructosamine testing. Continuous glucose monitoring system, CGMS, now available very frequently, and measurement of the fetal abdominal circumferences to know whether the baby is at good health or not. SMBG. All pregnant women with diabetes should perform the SMBG, that is self-monitoring of the blood glucose. The frequency and timing of the testing needs to be individualized. Some people will say fasting on the post-lunch. Some people will say fasting pre-lunch, pre-dinner, and some people will say 4 or sometimes 5 times, 6 times, etc. Ideally, insulin-treated GDM and in the pre-existent diabetes like type 1 and type 2 diabetes should be done 4 to 6 times a day. So the fasting before and after each main meal. However, in diet-treated GDM, SMBG can be done less frequently. So these are all individualized. So I have tested the 3 AM also to rule out your Somogyi phenomenon or the Dawn phenomenon. HbA1c in the pregnancy, useful in the early pregnancy to differentiate the GDM from pre-existing diabetes. May serve as a prognostic marker of the maternal and the fetal outcome. These 2 points I already discussed. May be spuriously increased consequent to the iron deficiency anemia. That is very important take-home point. So in all the iron deficiency anemia population, so the HbA1c levels may be spuriously high. So maybe 10 or the 11, and we blame the fellow. You see the HbA1c levels very high. Suppose if you check the hemoglobin, that may be the 6.5 or the 7.5 or 8. So that is the reason for this spurious increase. Suppose if the hemoglobin is 11 or the 12, the HbA1c may be 8 or 7.5. Need not be done for routine monitoring in the GDM. The fructosamine, a measure of the glycated serum proteins, index of the glycemic control over the preceding 2 to 3 weeks. So this is what we expect in the pregnancy, because in the true GDM, the second half, if you compare, if you see the blood sugar control with HbA1c, so 3 months you have to wait it. By the third month already delivered. So the 15 days at the 18 days, at the 2 to 3 weeks. So this is the fructoxamine test. Now it is available. So fetal abdominal circumference, big thanks to our radiology population. They are doing extremely good work as far as the fetal sonology is concerned. See, this is the transverse section of the fetal abdomen. Okay. Outer premiere of the abdomen measured, umbilical vein at the level of the portal sinus, stomach bubbles, kidneys. So these are the growth charts, fetal biometrics, interpreting the AC and the action plan. So abdominal circumference, more than 75th. Growth restriction. Here the 32 weeks gestation in the OPD with a scan report which shows AC at 90th centile and AF1 21. 2-hour plasma glucose 75 grams load 135. So this is another study. These are things. Here the female 35-year-old. So Gravida 3, Para 1, Live 1, Abortion 1. First LSCS, GDM and diet, section for the breech. Second, IUFT at 24 weeks. Third is the present pregnancy. So present pregnancy, GDM on the diet. So excellent control of the blood glucose. See, this is the how beautifully how to take the history of all these previous pregnancies. So it gives a lot of the information for us. See, this is the fasting, etc. See, this is the SMBG reading. See the blood sugar levels. Fasting 61. Are you happy? After breakfast 102. Before lunch 90. After lunch 112. Before dinner 91. After dinner 107. 3 a.m. 58. Okay. So showing a little bit hypoglycemia at 3 a.m. and the fasting. So we have to reduce the dosages. Acute metabolic complications of the diabetes. This is the logbook. So all the GDM population in high risk individuals, this you have to advise to the patients. So first they have to buy the glucometer. They should be known how to check the blood sugars on their own, and then how to write the blood sugars and at what times you have to. So they are supposed to do the blood sugar estimation. This is very important. See, hypoglycemia and the ketosis. Here the case study. See the blood sugar levels. Fasting 88, after breakfast 115, before lunch 95, after lunch 162, before dinner 100, after dinner 105, 3 a.m. 79. So only abnormality here is after lunch. What is it? 162. So what is your target? 120. Give one shot of regular insulin before lunch. Suppose the person is getting 10 units, increase to 12 units or 14 units. Okay. Suppose the person is getting for 4 units, just increase the before lunch regular insulin so that the after lunch blood sugar will be under control. So by seeing this logbook, so you can definitely have an idea. So which sugar is abnormal and how to control it. See here, see the logbook. Fasting, after breakfast, before lunch, after lunch, before dinner, after dinner, 3 a.m. So before lunch, getting little bit hypoglycemia. So when you are giving the regular insulin before the breakfast, so that you have to reduce by 2 units. 2 units. So hypoglycemia. Hypoglycemia may occur in the diabetic pregnancy due to stringent blood sugar, blood glucose targets. Nausea and vomiting in the early pregnancy may contribute. Insulin analogs and the pumps may reduce the risk of the severe hypoglycemia. Mild degree of the maternal hypoglycemia do not impair the glucose delivery to the fetus. That is a big thanks to our physiology. So these are all the symptoms and signs of the hypoglycemia. Already told several times: adrenergic hypoglycemia, glucopenic hypoglycemia, etc. So this is the management. Effect on the fetus. It can adversely but reversibly affect the fetal heart function. So hypoglycemia. Shown to be associated with increase in the small for gestational age babies. It can possibly affect the postnatal beta cell function. The animal study suggests that maternal hypoglycemia is a potential teratogen. So human evidence is lacking it. But still, I told you several times that hypoglycemia is a very, very dangerous, whether in the pregnancy or non-pregnancy. Don't allow the hypoglycemia in any of our diabetic individuals. Always see blood sugars logbook, see the logbook, and then adjust the dosages to avoid hypoglycemia. So DKA in pregnancy, especially in the type 1 diabetics. So they present with the DKA very often during the pregnancy. So these are all the precipitating factors. Your emesis, infection, non-compliance with your insulin therapy. So for 2 days or 3 days, they stop taking the insulin. In pregnancy, if they stop taking the insulin for even for the 1 day, so chances of DKA is very high. Pump failure, beta symptomatic drugs, steroids. For some reason, if you use the steroids, again, there is a chances of decay. The most important here is the two things to cause the decay in pregnancy. One is non-compliance. Kopam, intla valli meeda. So they stop taking the insulin, they land up with the decay. That is the first thing. And the second thing is the infection. Maybe urinary tract infection, maybe respiratory tract infection, maybe skin and subcutaneous or abdominal infections. Symptoms, you all know that: hyperglycemia, polyuria, polydipsia, nausea, vomiting, abdominal pain, and weight loss. And signs, so there will be tachypnea, there will be tachycardia, there will be Kussmaul's respiration, so hyperventilation, tachycardia, ketotic breath, hypotension, dry mucous membranes because of the severe dehydration, disorientation, and coma. If you check the lungs with your stethoscope, a beautiful lung sounds. So normal breath sounds in a fellow who is dyspneic, so always think of metabolic acidosis. Okay. Suppose if it is because of the pneumonia, you will have maybe Krebs, or maybe the Rales, or maybe the cavernous breathing, or maybe the bronchial breathing, etc., etc. But a normal, even if you take an X-ray also, that could be the normal in metabolic acidosis. But the fellow is severely dyspneic, hyperventilation, Kussmaul's respiration. So always think of the DKA, check the urine ketone bodies, that will be the positive, blood sugar will be very high, and ABG, pH will be less, maybe 7.1 or maybe 6.9, etc. And the bicarbonate may be 18 or the 20 or etc. So definitely it's a case of DKA. So again, I told you many things about the DKA management. Number 1 is the fluid management. Number 2 is the insulin management. Number 3 is the electrolytes management. So here the fluid, insulin, and electrolytes. Search for and treat the precipitating cause, especially the infections in Indian population. So patient should be admitted to a high dependency unit, supplemental oxygen, left lateral position to avoid the aortocaval compression, monitor the fetal heart rate. This is very, very important. Monitor the urine output. All cases of a suspected DKA in pregnancy should be shifted to the specialized centers after the initial stabilization. Here, 33-year-old lady with type 2 diabetes of 4 years duration. Hypertension for 3 years. Well controlled on telmisartan and amlodipine. She is now planning to conceive. What changes would you make to her medications? Excellent answer. Stop telmisartan, continue amlodipine. So benefits of treating severe hypertension is clear in pregnancy. Treating mild to moderate hypertension in pregnancy is less clear. Recommended BP to reach would be 120 to 140 of systolic, 80 to 90 millimeters of the mercury of the diastolic. But I say that not even the 140, maybe 120 to 130, or maybe 110 to 130. Diastolic 80 to 85, not even the 90 also. Because the more the blood pressure, more the consequences on the fetal outcome. So these are the drugs, already discussed the drugs, methyldopa, labetalol, your amlodipine, and etc. Now the most important part of our discussion is obstetric management. Antenatal visits, pakka. Monitoring of the fetal growth and the well-being, that should be done. And timing and mode of the delivery. Traditionally, antenatal visits are scheduled as follows. Booking till 28 weeks, once a month. 28 to 36 weeks, once in 2 weeks. So once in 15 days. 36 to delivery, once in 7 days or once in a week. All the antenatal visits, what they do? Menstrual history and the date of the LMP in the first antenatal visit. BP recording, weight management, dietary advice, glycemic control, HbA1c in the first antenatal visit, urine routine for any pus cells, etc., or any ketone bodies positivity. If there is a urinary tract infection, send the urine for culture and sensitivity. Renal function tests like serum creatinine, albumin creatinine ratio. So the more the serum creatinine, definitely you have to terminate the pregnancy. Retinal examination, proliferative diabetic retinopathy, contraindication to the pregnancy, or if it is non-proliferative diabetic, retinopathy, we can continue the pregnancy. Counseling for the risk of the congenital anomalies. So that's very, very important. So don't give a guarantee for a 100% healthy child, healthy newborn. So there is always a chances of the congenital anomalies are there. You please discuss with them, with both the partners. So USG for the fetal viability and the dating, and continue the folic acid supplementation, and maybe a low dose in aspirin in certain cases. Good glycemic control at conception, always good. These are the antenatal visits, second trimester. That is the first trimester antenatal visit. Here the second trimester. So again record the BP, weight management, urine albumin, ultrasound examination. Look for preeclampsia or polyhydramnios. Identify and treat the urinary tract infections or vaginal candidiasis, because the diabetics, they are more prone for the monilial infections. Give good dietary advice. Monitor the glycemic control, your logbook, renal function tests, again the creatinine clearance, etc., and retina examination. Now the third trimester. BP, weight, albumin, ultrasound, watch for the preterm labor, good dietary advice, glycemic control, and renal function tests. Fetal growth and the well-being, early pregnancy scan, 7 to 8 weeks. Dating and the viability. Dating important to offer the appropriate timing for the future scans. Accurate dating prevents the iatrogenic prematurity. 11 to 13th week. Should be offered to all the pregnant women. In trained hands, can pick up 60% of the structural anomalies. Combined first trimester screening to be offered as per the non-diabetic pregnancies. 18 to 20 weeks. Detailed scan to ensure the structural normalcy, because organizations have occurred by this time. So you should have a detailed scan. What the name given to that scan? Some TIFA or something like. Okay. Fetal echo is also very important here. So serial growth scans. Monitoring the fetal growth and the well-being. So there is a normal versus abnormal. Loss of variability is the most ominous sign. Fetal compromise. So processes implicated as cause the fetal compromise in the diabetic pregnancies. So fetal hypoxia, fetal ischemia, alterations in the maternal fetal metabolism. Reactive hyperinsulinemia contributes to the hypoxia, causes the increased fetal oxygen consumption, decreased arterial oxygen levels. These metabolic changes increase the risk of stillbirth besides the IUGR and preeclampsia. Ultrasound not useful to pick up the metabolic causes of the stillbirth. Management. Medical termination of the dosing depending on the gestational age. Insulin requirements may decrease and should be monitored. Another case, 33-year-old lady, G4, P3, abortion 1 with GDM, presents to the labor room at 28 weeks of the gestation with preterm labor. She had GDM during her 3 previous pregnancies as well. What is the significance of her history? What is the status of her fetus at 28 weeks? And what are its chances of survival if delivered at this point? Timing of the delivery depends on the severity and duration of the diabetes as well as its comorbidities. Risk of IUFD is more in pre-existing diabetes, hence they may need to be delivered earlier. Need to balance the risk of prematurity and RDS against the risk of the late intrauterine fetal death and macrosomia. So timing of the delivery too early, respiratory distress syndrome and prematurity, and a late delivery, late IUFD and macrosomia. So it is like a very, very tough decision should be taken by the obstetricians, not too early, not too late. Gestational specific risk for the stillbirth continue to fall up to 38 weeks and increase slightly in the postdated pregnancies. In women on insulin, most would plan delivery at 38 completed weeks. So most of our people know, most type 1 diabetes, etc., there are multiple insulin therapies. So 38 weeks, after completion of the 38 weeks, that is the right time to go for the elective seizure. In diet control diabetes, aim to deliver at 40 weeks. So it is the ABG's decision, OBG's specialist decision to take between 38 and the 40 weeks. So less than the 38, too early, and more than the 40 weeks, too late. Here 42 years, GDM at 18 weeks of the gestation and advised insulin. She didn't comply with the advice and scan around 30 weeks showed AC 95th centile and AFI 20. Cervix is 1.5 centimeters long and 2 centimeters dilated. How would you manage this lady? She gets discharged against the medical advice and comes back with a scan report at 35 weeks. So first presented with 18 weeks of the gestation, scan around 30 weeks. At 35 weeks, cervix is 3 centimeters dilated, 1 centimeter long. When would you like to deliver her? How would you prepare for the labor? What postnatal advice would you like to give? So these are the risk of the prematurity. So the pre-existing diabetes predisposed to both induced and the spontaneous preterm births. Iatrogenic prematurity happens when the additional complications such as preeclampsia or nephropathy arise. Equally, in poorly controlled GDM, preterm delivery may be planned due to the concerns of the unexplained fetal demise. Antenatal steroids. Early delivery is contemplated. The risk of iatrogenic prematurity and respiratory distress syndrome must be considered. So GDM is not a contraindication to the antenatal administration of the corticosteroids for enhancing the pulmonary maturity. So sometimes they take a decision to introduce the steroid therapy to improve their pulmonary maturity. Inpatient care is not mandatory. So these are the antenatal steroids. Day 1, day 2, day 3, day 4, day 5, day 6. So when you are using the steroids, obviously the blood sugars will go up. So you have to increase the doses of the insulin according to your steroid therapy. Tocolysis, both adrenergic agonists like ritodrine can cause hyperglycemia. In combination with the steroids, the glucose levels will increase and need to be covered appropriately with the insulin. Nifedipine does not affect the glycemic control and so preferred in the gestational diabetes. Here 33-year-old lady presents in the 38th week of the gestation. 3 prior uncomplicated vaginal deliveries. The estimated fetal weight at this time is 4.6 kgs. How would you counsel her about the delivery? Already 4th delivery, 33 years. After extensive counseling, the couple declined elective cesarean section delivery. How should she be managed at this point in time? Extensive counseling. She needs extensive counseling. Mode of the delivery. Vaginal delivery is safe in gestational diabetes. No contraindication to the vaginal delivery. Induction of the labor is a safe option with a previous obstetric history or EFW or other clinical factors. What is EFW? What is EFW? OBG? Okay, estimated fetal weight. Okay. LSCS only for the obstetric indications. So not all GDMs should be delivered by LSCS. So LSCS indication is for the obstetric indications. Be prepared for shoulder dystocia and the PPH. So cesarean section for the macrosomia. Need to maintain the glycemic control, intrapartum also. Both antepartum and intrapartum hyperglycemia increases the risk of the adverse neonatal metabolic complications. Now we are worrying about the fetus for hypoglycemia, etc., etc. So good intrapartum glycemic control reduces the risk of the fetal acidosis and the neonatal hypoglycemia. In non-diabetic pregnant women, glucose turnover increases 4-fold in the labor without change in the insulin levels. The skeletal muscle and uterine contractions are the major determinant of the glucose levels during the labor, irrespective of the insulin levels. Insulin requirements usually decreases during the labor. The work of the labor requires the energy. Oral calorie intake is typically reduced. Main objectives of the management to maintain the normal glycemic values, maintain the adequate hydration, and ensure the adequate calorie intake. These three are very important. So give the proper insulin to control the blood sugars very effectively. Hydration is very important. Maybe the normal saline or the dextrose normal saline DNS. Ensure the adequate calorie intake. Women with the GDM and diet control alone rarely need the insulin in labor. If labor is augmented and IV fluids on the flow, so blood sugars can be monitored. So that is your drip. Insulin drip can be used here, maybe 1 unit or 2 units per hour. The day before the labor, women on insulin therapy for pre-existing diabetes or GDM should follow the usual diet and the insulin regimen. On the morning of the delivery, skip the breakfast and morning regular or the rapid insulin. So on the day of the surgery, so don't give the insulin and tell to the anesthetist about the skipping of the insulin at that time. So the anesthetist will check the blood sugars during the intraoperative period. And if the blood sugars are more than the 180 or more than the 200, then we can introduce the intravenous insulin therapy. Otherwise, you don't require any insulin. So our goal of sugar during the labor is between 140 and 180. Check the blood glucose measurements every 2 hours during the labor. So this is the intrapartum. Insulin levels. See, once the sugar levels are less than the 90, so that is the time to start the dextrose normal saline. IV infusion of 1 to 2 units regular insulin and hour, along with the 5% dextrose or the normal saline. Women and the pumps. Immediate postpartum management. So we discussed about the antenatal management. We discussed about the intrapartum management with the insulin, more the blood sugars, insulin, etc. Now the postpartum. A pediatrician skilled in the neonatal or research station should be present. Clamp the cord early to prevent the polycythemia. Evaluate the vitals and Apgar score at 1 and 5 minutes. Keep the neonate warm and transfer to the incubator. Preliminary physical examination to detect the malformations. Monitor heart rate, respiratory rate, color, and motor activity for at least 24 hours after the birth. Promote early breastfeeding. That is the most important. Monitor the neonate's CBG at 1 hour after the delivery and before each of the first 4 breastfeeds. Values less than 36 warrant the treatment. Top feeds, glucose, water, or IV dextrose. Check the calcium levels on the day 2 in the macrosomic infants. So mother's glycemic status. In most cases of the GDM, diabetes resolves after the delivery, 96%. Insulin requirements usually come down completely or reduce significantly. No insulin is required. However, it can persist in about 5 to 10% of the cases, may represent unrecognized pre-existing diabetes. So they continue to be a diabetic even after the delivery also. So this can be ruled out by performing a few capillary blood glucose measurements in the first few days after the delivery. Abdominal values, that is more than fasting, more than 126, BP more than 200. So they need a regular diabetic management. Recurrence, 1/3 of the women have a risk of the recurrence. Risk is higher in the older women, multipara, and a higher inter-pregnancy weight gain. So the more the obesity, more the weight gain, more the para. So definitely these people have a higher recurrence of the GDM. So these you know that. Follow-up. Based on the results of the OGTT, the diabetes, start the treatment, pre-diabetes, intensive lifestyle changes with the normal. Again, the intensive lifestyle changes, repeat the OGT annually. So the most important point here is, even though they are the normal follow-up care, lifestyle modification is very important. Otherwise, these will be turned to be a type 2 diabetes at an early time. And repeat the OGTT annually. 6 weeks, 6 months, annually. See here, 34-year-old second gravida found to have the GDM at 27 weeks and was put on the insulin. Following the delivery, blood glucose was normalized and she was able to stop the insulin. After 6 weeks, she advised 6 weeks OGTT. She underwent the OGTT with 75 grams. Now the results are like this. 82 and 127. Normal. What is the risk of developing the diabetes in the future? Low risk. When should you be tested again? Now the 6 weeks. Yes, 6 months. Got right answer. So next test, 6 months. Now during the lactation, insulin remains the treatment of the choice if the person happens to be a diabetic. So don't give the OHS during the lactation, because most of the OHS will pass on through the milk. So don't give the OHS during the lactation. Insulin is the drug of choice. Glibenclamide and the glipizide are not secreted in the breast milk and can be safely used. Metformin is secreted in the breast milk, but does not seem to have any adverse effects on the baby. However, larger studies are needed before it can be recommended. So the safe drugs are the glibenclamide and the glipizide. Follow-up care and long-term consultations. Risk of the future type 2 diabetes. Risk of the GDM in the subsequent pregnancies, because the past history of the GDM is a big risk factor for the recurrence. And contraception. This is also very important. Here, 40-year-old lady, fasting blood glucose 154 on her annual checkup. She gives history of GDM during her second pregnancy 6 years ago, following which she was delivered a healthy 4.2 kg baby by CS. She has not checked her blood glucose level since until the present visit. So this is a routine our Andhra patients. So whenever you see a fellow at 40 or 45 years of the diabetic life, if I ask a direct leading question, are you in any history of the GDM? Yes. Any follow-up after the GDM? No. So this is very important follow-up. So what is your diagnosis here? Type 2 diabetes. Type 2 diabetes following GDM. So what is the next step? Same. You get the fasting blood sugar, PV blood sugar, HbA1c, lipid profile, thyroid profile, liver profile, renal profile, electrolytes. Okay, so all these things, and then the dietary approach, your exercise, your yoga, your meditation, your metformin, your gliptins, your SGLT inhibitors, etc. Because she is already 40 years, she is not in the lactation period. Already 6 years history is there. So now you can as well treat it as any routine type 2 diabetes. But here the risk for this diabetes is because of the GDM. Women who have had a GDM are at high risk of developing the type 2 diabetes in the future. The rate of conversion varies from 35% to 60% over the 10 years. Okay. Whereas in India, it may be 100% over 5 years. The Western slide. So there, 35 to 60% over the 10 years. But in India, in our Andhra Pradesh, maybe 100% over 5 years. Waist circumference and BMI are the strongest anthropometric measures associated with the development of type 2 diabetes in women with the GDM. That means abdominal adiposity. Okay, not the BMI. The abdominal adiposity and waist hip ratio, this is much more superior than the BMI in our Indian population, especially in our GDM population. So type 2 diabetes develops 50 to 75% of the women with the BMI more than 30 and history of the GDM versus less than 25% of the women with the GDM who achieve the normal body weight after the delivery. So what are the risk factors for the progression to the diabetes? Overweight or obesity, member of the high ethnic risk group of Indians, family history, GDM diagnosed in the first trimester are at high risk rather than the GDM diagnosed in the 8th month or the 9th month of the pregnancy. So earlier the GDM, the more the chances of conversion to the type 2 diabetes. And then the need for the insulin during the pregnancy. Suppose some people that they treated with the MNT and the metformin, less likely to have the type 2 diabetes, whereas the insulin therapy during the GDM fellows are at high risk of getting the type 2 diabetes at later time. Need for the nighttime insulin during the pregnancy. Usually you don't use the nighttime insulin, but if you are using the nighttime insulin during the GDM, again high risk of converting to the type 2 diabetes. And persistent impaired glucose tolerance after the delivery. So even after the delivery, the blood sugars are a little bit higher. They are not the normal, neither normal nor diabetic, but they are in the pre-diabetic range. Again, they are at high risk of getting the future type 2 diabetes. They are very, very important. So women with GDM are at high risk of developing the cardiovascular disease and developing it at a younger age than the women with no history of the GDM. So not only the type 2 diabetes at an younger time, they are at risk of getting the cardiovascular diseases. So diabetes is nothing but cardiovascular disease. What are the preventions? Weight loss is a very, very, very important. Regular exercise. Possibly medications, especially in women with the pre-diabetes post-delivery. Management of the additional cardiovascular risk factors. Contraception. Women with diabetes and GDM can utilize all accepted methods of the contraception. During the lactation, progesterone only pills are safer than the COC. Use of progesterone only pills is also associated with a minimal risk of thrombosis, reduces by 6 weeks postpartum. Depot metroxyprogesterone acetate, DMPA, increases the risk of subsequent diabetes from the weight gain. So, POP are the ideal drugs for the contraception here. Effect of progesterone and higher dose of the estrogen and the metabolic parameters in women with type 1 and type 2 diabetes may have to be kept in mind if control is poor or if there is dyslipidemia. IUCD may be the choices for such women. Good glycemic control should be achieved prior to the subsequent conception. So offspring, already I told you, the prevention, education, etc., lifestyle modifications, dietary approach. Effective management and follow-up of the GDM can prevent the type 2 diabetes across the generations is a very, very important. So take-home messages. Pregnant women with diabetes should perform the frequent SMBG and adjust the therapy accordingly. More frequent and intense obstetric monitoring is indicated. Timing and mode of delivery is dictated mainly by the obstetric consents. Following the delivery, most GDMs can stop the insulin. They need a follow-up after 6 weeks, 6 months, and then the yearly and lifelong observation for the development of type 2 diabetes in both the mother as well as the offspring. So thank you very much for your patient hearing. So that